Good morning, everybody. So once the environmental factors and low dose of atropine is covered, I'll be covering the optical correction modes of myopia and what's new and what works. So I have no financial interest to disclose. We have all heard about the global crisis which myopia is going to have. So in all this, the key message is that we should aim to slow down the progression of myopia and see to that all children should have myopia less than 3 diopters and an axial length of less than 26 millimeters, because if the axial length is above 26, it doubles the risk of visual impairment due to cataracts, retinal detachments, and maculopathy, and the same stands true for even 1 diopter increase in myopia. So the global crisis has been covered. I'll just touch upon the Indian scenario. According to the study by Dr. Rohit Saxena, it has been shown that though the Indian scenario is not that alarming, we have seen the prevalence of myopia is just 7.5% in 5 to 15 years of age, but we have seen a more increase in myopia in the urban population as compared to the rural population. And thanks to the COVID pandemic, the terminology of quarantine myopia which has come up, and the various factors which are involved in myopia progression. So I'll be covering the optical devices which are used for myopia. So Dr. Shruti has already explained, but I'll just reinforce about this for the audience which have joined later. So what myopia does is, a myopic eye basically has a longer axial length more than the equatorial diameter, which causes the cornea to be a more prolate shaped cornea, causing a hyperopic defocus in the periphery. So what we giving with the single vision correction lenses is that we are focusing only the foveal vision, but the peripheral vision is hyperopic, which causes increase in axial length and myopia progression. And sometimes we see that the kids with myopia have a accommodation lag, which causes retinal image better behind the retina, causing hyperopic defocus even at the center. So kids having a accommodation lag will further show faster increase in myopia. So first of all, we'll cover the spectacle correction. We have single vision lenses, we have progressive addition lenses, and the bifocal spectacles. This is the best bet available as of now because they are easy to fit, affordable in the Indian scenario, they are better acceptable and are non-invasive, can be given to younger children and kids who are not suitable for contact lens usage, can be used as an adjunct treatment and a backup correction combined with the atropine, low dose atropine drops. Single vision lenses, you should always make sure that you don't do under correction. Full correction should be given because there's a positive correlation of under correction with a greater increase in the myopia progression. And once the child is seeing blurry, the child will avoid going outdoors, and this will add on to the progression. Progressive lenses have been tried, in which we have seen that a large zone of ad is given in the inferior zone, which creates a relative myopic shift in the upper field, which causes that the near focusing effort while reading reduces, and this has shown to decrease the myopia progression. So there are various studies which have been done on the progressive addition lenses. The COMET study, which was done in 2001, this is the largest RCT which has been done on PALs, and they have seen that though the myopia progression reduces with PAL, it is statistically significant but clinically not very significant, and the greater control was seen in children with higher accommodation lag, with near esophoria and a lower refractive error. So this was a 3 years RCT which was done, and in the COMET 2 they continued to study these further children. There were a lot of dropouts, but 118 children were further studied, out of which 110 completed the post 3-year study, and there was a clinically very small difference in myopia progression of only just 0.28 diopters. In the STAMP study, they have reported that the use of progressive addition lenses is still questionable, and one ad is not suitable for all type of children. Bifocals have also been used with a 1.5 addition as an E segment, and even with a prismatic effect of 3 prism base in prisms. So use of bifocals have reported a moderate control in myopia with a 35% reduction in the axial length and 60% reduction in the refractive change. And better results have been seen with prismatic bifocals in children with a lower accommodation lag. So various designs have been studied. The common one is the MyoVision by Zeiss. So they have different lens types depending on the central clear zone and the peripheral near ad which has been given, and the prismatic bifocals by SLR. So when, according to this study by MyoVision, they have not found any statistical significant difference in the rate of myopia progression with the MyoVision lenses as compared to the single vision lenses. So overall, if we see the refractive error and the axial length were matching in both the control and the MyoVision group. The latest novel design is the DIMS, which is the defocus incorporated multiple segments by Hoya, which is MioSmart. So this basically consists, these are spectacle lenses, which consists of a central clear zone, which is 9 millimeter. And there are small segments of circular segments of around 1 millimeter. They are around 400 multiple segments, which create a defocus in the periphery. So yeah, so yeah, you need a white. Yes. Yeah. You need to hold on a black. Put a torch and show it on the dark. Can you see the rings? It's not seeing. They'll be seeing more. Yeah, you can see the rings. Put it. Shine a torch and put it against the dark wall. You can see it. So you will see later. You can see. So you can see multiple small segments after the lock. You can actually see this. Yeah. So various studies have been done on DIMS. So in for 2 years follow-up, they have seen the increase in axial length in the myopic progression was just 21.5%. Kids didn't show any myopic progression, and only less than 1 diopter was seen in 65.8% of the children. And the axial length growth at the 2-year follow-up was just 13.9%, which showed zero progression, and 57% had less than 0.3 millimeter of axial length progression. They have recently published the 6-year data also, which they presented in AIOC2022, which they have shown that kids who shifted to single vision lenses showed a higher myopic progression than who continued with the DIMS lenses. So this is just a slide showing that the vision quality with the MyoVision, which is the bifocal lens, and the MioSmart lens. So there was greater peripheral blur with MyoVision lenses as compared to the MioSmart lenses, which are the DIMS lenses. Further, SLR has this HALT lens, which is again a similar lens, but there is an array 11 aspherical lenslet zones which are seen, and the central clear zone which works on the same theory. So now contact lenses, they are conventional. So So there's lots to cover actually. So the soft multifocal contact lenses have been studied, but then obviously there is a limitation that they are available in only limited powers. And single vision lenses have showed higher progression than the near addition, which is the dual focus lenses. The latest is the MeSight lens. So then the orthokeratology, which are overnight wear rigid lenses, but then there are issues of, again, using contact lenses in kids. Then there are various studies which have been done on contact lenses with the use of ortho-K lenses. If we compare spectacles with contact lenses, obviously contact lenses have reported a better control than the spectacle lenses. So what to prescribe? This is my final slide. So if a child is less than 8 years of age and the parents are not motivated, go in for spectacles. If the child is above 8 years of age, we can try ortho-K lenses. And among spectacles, if the child has a normal accommodation, so you have to check for the accommodation lag, then single vision lenses along with atropine 0.01% if they are showing a pure axial length growth. In cases we are seeing a accommodation lag with esophoria, progressive addition lenses is the best bet. Orthophoria, you can use bifocals, and if the child is exophoric, go in for prismatic bifocals. So take-home messages, there are multiple options available. We should first understand the parent expectations, affordability, and we have to counsel that nothing guarantees 100% efficacy, and we cannot stop progression, but we can slow down the progression.